All right. So
Very
you know
good.
me.
Let me introduce you guys. Claire Dempsey. She's joining us with a lot of expertise and a great attitude. She loves to teach. She loves to share her knowledge, and we very much appreciate that. I hope everyone is having a great day and ready to more learning.
Okay, let's do it. So yeah, thanks everyone for joining. I know it's a weekend and you're all very busy, so let's make this interesting. So what we're going to talk about today is imaging technology in radiotherapy. So really, I'm just going to kind of run through some very basic physics about how imaging, different bits of imaging equipment work, and then we'll start to see how that all links into IMRT and VMAT, and then also into IGRT as well. So let's get started. So just an outline of what I'm going to talk about today. So we're going to look at how imaging technology has changed, how advancements in imaging technology has changed simulation and treatment planning. So really looking at using CT for simulation and planning, and then how the imaging technology and advances to that has changed imaging for treatment and treatment verification. And then just a quick introduction to image-guided radiotherapy. And I know you guys will have quite a few sessions after this on IGRT. So it'll just be an introductory component. And I know that the team in the next few weeks will also be going more deeply into that area as well. Okay, so let's start off with the first one. So how imaging technology has changed for simulation and treatment planning. So really this is about incorporating CT into your simulation and treatment planning processes, particularly around IMRT and VMAT. So let's go to the absolute basics of physics behind how these images are created. So when we have our X-rays, we have photons or particles of radiation that pass through our patient and then they hit a detector. So some of those photons, as they pass through the patient, will interact with the patient and be absorbed. And then some of the photons will pass through the patient. So when we have tissues with higher electron density, they absorb more photons, meaning less photons that pass through that tissue will hit the detector. And we see that as kind of the lighter part of the image on our X-ray images. And tissues that have a low density will absorb less photons. So more photons will pass through that part of the patient and will hit the detector. So that's where we get the darker part of the image. Unmute. Okay, so, okay, everyone can hear me? Perfect. So you can see on this image, obviously, when the radiation passes through the lung, the tissue is less dense, and so more photons pass through, and that makes the image that we see darker. And obviously bone absorbs more of the radiation, and it makes the areas of the image appear lighter. So that's really the basic physics behind how these X-ray images are created. So how is a CT scanner different to a normal X-ray imager in terms of how does it work? So your normal X-ray imaging unit provides a 2D image of the area of the patient that you're looking at. So you've got your square rectangular X-ray beam, hits the patient at a certain angle, and then obviously the photons that pass through the patient hit that large detector, and we get an image like you've just seen on the previous slide. What a CT scanner does is it uses all angles around the patient to create the X-ray image. So to do this, we have an X-ray source that rotates around the patient, and then a series of detectors on the other side of the patient, so on the other side of the scanner, rotates in conjunction with the X-ray source, and it detects how many photons are passing through that part of the patient. So this is just, I guess, a diagram of how that looks. So we have our rotating X-ray source that goes around the patient. On the other side of the scanner, we have a series of X-ray detectors. And so as our X-ray source rotates around the patient, the X-ray detectors will pick up how much radiation is passing through the different parts of the patient at the different angles as it passes around the patient. So if we have a single rotation of the X-ray source and the detectors, so if the X-ray source does a single lap around the patient, the detectors will create an image of a single axial slice through the patient. So you get an image, a bit like this slice through the brain here. So what then happens is obviously the patient on the table is moved through the CT scanner, and the X-ray source and detectors continue to rotate, and that's how we can generate the multiple slices through the patient. So you can see in this image down the bottom, we have multiple slices for each rotation that X-ray scanner and those detectors do around the patient. So then we can add those multiple slices together to create a beautiful 3D image of the patient. So just, I guess everyone's seen a CT scanner, I assume. This is just the inner workings of the CT scanner. So we've got our X-ray tube sitting up here at the top, and then there's a collimator that collimates that X-ray beam into a nice sort of uniform shape. And then we have our detectors, our data measurement system on the other side of the CT scanner. So if we just think about what you guys learned in session 6, was really about simulation principles for IMRT and VMAT. So you've already learned that you can't use your conventional simulator excuse the typo there, that should be IMRT, not IRMT, and VMAT planning. So if you remember, when we do IMRT and VMAT planning, we need to have that beautiful 3D volumetric information. So all those contours that yourselves and your radiation oncologist has to do to contour the target and the organs at risk and all those kind of things for our inverse planning, which is, as you recall, when you put all your different, I guess, your goals, your treatment goals for all your different volumes, and then the planning system works out the best plan for you. So we need to have that volumetric information. So if you use a conventional simulator where you're getting those 2D images, it's really not enough information for us to create that 3D volumetric information. So this is why we need to use a CT scan for IMRT and VMAT simulation scanning. So it's an essential for doing IMRT and VMAT scanning. So a little bit of physics stuff here. So obviously, when we see our CT scan, we can see our patient in 3D and we can contour all the volumes, which is really important for IMRT and VMAT planning. But there's also some other important information that we need in order to create accurate dose calculations in our patient and our treatment plans. And this is something called Hounsfield units. So a Hounsfield unit, it's dimensionless. It doesn't have it's not centigrade, it's not centimeters, it's not kilograms, it's dimensionless. And it's just a value that you use in CT scanning, which relates the grayscale, so how dark a particular pixel may be within your image, to the amount of radiation that has been absorbed by the patient or by the tissue that the radiation has passed through. So a Hounsfield unit relates the absorption of radiation in a tissue, so the various different tissues within the body, to the absorption of radiation within water for a given radiation energy. So basically what we see is that the Hounsfield unit value for water is equal to 0. And so this is just an equation here. You don't need to remember the equation, but it's just, a little bit of physics, math kind of stuff that might interest some of you. So you're just looking at the difference in what we call absorption or attenuation of radiation in tissue compared to that of water, and you get this value called a Hounsfield unit. So why are Hounsfield units important? So what we use them for is by using the grayscale of an image in your CT image, we can work out the type of tissue in each pixel, so each sort of individual, I guess, dot or small square of our CT image, to then determine the type of tissue that is inside the patient. So whilst it might seem obvious, this is a bone and this is, you know, fat or whatever, sometimes there's other tissues you're not quite sure if they're density or if you've got contrast, say, in your patient, you want to determine whether it's contrast or whether it's really another type of fluid or whatever. This is where the Hounsfield units become really important, because we define those Hounsfield unit values and we actually give them different densities or different physical properties, I suppose. So, you know, for example, we've already said that water has a Hounsfield unit of 0. And you'll see that things like fat and muscle have Hounsfield units not far off things like water. So they're all sort of sitting around that sort of water volume. Bone usually has a Hounsfield unit around about 1,000. Air has a Hounsfield unit of about -1,000, and Hounsfield units can go up to extraordinary numbers. So things like titanium can have a Hounsfield unit value of 14,000. So, you know, it can go up to very, very high values for things that have extremely high electron densities. But you can just see within one image, we can distinguish between different tissues within the brain, different densities of bone, all those kind of things from these Hounsfield units. So, and why is that important? So knowing the type of tissue inside the patient is important so that we can accurately calculate the dose inside the patient in the treatment planning system. So this then helps us to generate really good quality treatment plans where we know and more accurate treatment plans. So we know that the dose the treatment planning system tells us is accurately delivered in our patient. So just as a comparison here, we've just got a single beam passing through a patient through their lung without any tissue or density information applied into the image. So you can see it's just a straight beam passing through the patient. The only thing that's taken into consideration is the contour of the patient's skin. And then this image on the right, we've now applied a tissue density information. So we now start to apply our Hounsfield unit information into the image. And you can see the dose distribution has started to change. So you can see in the lung where we've got really low density, we're starting to see scattered radiation. So our acidosis is starting to sort of spread out laterally. You can see that in the bone, we're starting to get a decrease in dose or an increase in absorption in the bone and a decrease in dose beyond the bone. So all this information makes our treatment planning calculation system more accurate by incorporating that information. So we have the Hounsfield units, and what we need to do is convert that to relative electron density, or RED. So you might hear of like an RED curve or an RED to HU curve, and that's what this sort of thing looks like. So here we're looking at our Hounsfield units and then converting that into relative electron density. So the reason we use electron density rather than physical density is all about the fact that we're now looking at radiation and how radiation interacts in a patient. And so it's really the electrons that are important in a tissue to determine how much dose a patient is going to receive. So rather than physical density, we look at electron density because it's the electrons within the tissue and the electrons that are created from the photon interactions that start to cause the damage to the patient, and that's where we get our radiation dose from. So that's why we need to look at electron density. So you can see water has a relative electron density of 1, so across here, and a Hounsfield unit value of 0. And you can see our soft tissue values are all lying pretty close to that of water, and they all have a pretty similar relative electron density. And this is why if you see your physicists, when you're, say, commissioning a new machine, and they wheel out a big tank and they fill it with water. This is why we use water for a lot of our measurements, because, the human body is made up of 75% water. So, okay, maybe you can correct me, maybe it's 80% water. And obviously a lot of soft, and obviously a lot of soft tissue as well. And you can see that all of that lies around about the same electron density as water. So that's why we can use water to do a lot of our measurements, because it really does simulate quite well the tissue inside a patient. So now let's just think about session 3, which I'm pretty sure I taught you. And remember we were talking about radiation beam and different fluences. So if you have a radiation beam with a flat profile, you can change the outside field shape, but you still have a flat sort of beam profile within that field. But what happens when we have IMRT and VMAT is we start to make adjustments to that individual sort of beam that's passing through the patient, and then we create a non-uniform fluence. So in this particular beam, you'd have a lot more photons passing through this part of the beam and a lot fewer photons passing through this particular part of the beam. And that's all shaped around where our target is and how we're trying to minimize dose to the surrounding organs at risk. So we're just kind of thinking about that at the same time. So when we're doing an IMRT or VMAT plan, the fluence of each beam that we just looked at is not only related to the shape and the position of our target volumes and our organs at risk, but it's also related to the electron density of the structures and the tissues that the beam passes through. There's a lot of things that the planning system has to think about. So without information about electron density in the treatment planning system, the treatment planning system can't optimize the treatment plan correctly. So if you think about that slide I just showed previously that had no electron density information and some electron density information, you can see that the dose distributions were quite different. So the planning system needs that information, again, when it's doing an inverse plan, to better create a plan that's going to work well for your patient. So it's important to understand how different electron densities, so tissue, air, bone, metal, can impact on a radiation beam. So then you can help the optimizer during treatment planning. Because remember, it's only the information you feed the optimizer that helps you generate a good treatment plan. So the more information you can provide the optimizer, the better the plan the optimizer is going to be able to provide you as well. So let's have a look at what radiation does in tissues of different densities. So let's just think about our typical percentage depth dose in water. So, let's say for a 6 MV beam, we have, our build-up dose, we get to 100%, around about 1.5 centimeters, and then we have this dose drop-off as the radiation passes through the water. And radiation, like we've seen, soft tissue has a Hounsfield unit electron density, much like water. So the radiation drops off in soft tissue, much like it does in water. But what does radiation do if it passes through something that isn't soft tissue or water? So what happens if the radiation passes through something of low electron density, such as air? Okay, so I might spend a little bit of time on this slide just so you can understand it. Okay, so this white curve here is our typical dose drop-off curve, assuming that all of this area is water. Okay, if we now look at this grey area here, and let's assume that that's air, the pink curve you can see is the change in the dose drop-off in the patient as the dose passes from tissue to air and back into tissue again. So you can see it's not quite the same as just going through water. So immediately in front of the air cavity, so let's say immediately in front of our lung or another air cavity in the patient, you'll get more of a dose drop-off here. And this is because you're getting less backscattered radiation into that part of the tissue because there's no tissue behind it to scatter radiation back into it. As you pass through the air cavity, the dose drop-off is going to be less steep because there's going to be less interactions going on, less dose being absorbed in an air cavity. And then as you sort of come to the end of the air cavity and hit a tissue barrier, you'll get a slight increase in dose immediately in front of that interface due to an increase in backscattered radiation coming off the tissue. And then beyond the air cavity, you get a small build-up region again, and then you have that dose drop off the same as you would for water, because you're back in that sort of tissue area again. So you can see if we don't have that information in our planning system, our dose distribution is going to be incorrect or not as accurate. So what happens if we've now got our radiation being passing through tissue, and then it's going through bone, and then back into tissue, and then through bone, and then back into tissue, or water, bone, water, bone. So again, this white curve here is what your typical dose drop off would look like if you were just passing through water. And this pink one is what you would actually see the dose drop off looking like passing through these different density tissues. So again, you'll get an increase in dose. So if you remember my previous slide, we got a decrease in dose because of the lack of backscatter. Whoops. In this one, we get an increase in dose immediately in front of the bone because we have an increase in backscatter. Because bone is a higher electron density, you're going to get more radiation backscatter off the bone, so you're going to get an increase in dose. We're going to get an increase in dose drop off through the bone. The bone's going to absorb more radiation, so the dose is going to drop off more quickly in bone. And then you're going to have a build-up effect as you go from bone back to water. And then again, an increase in dose because of the backscattered radiation, and so on as it passes through the different parts of tissue. So you can see if we've just passed through bone, we're going to have a lot less dose now reaching the tissue beyond the bone than as if there was no bone there. And if we think about something like titanium or a patient with an implant who has a really high electron density material in them, the effect that you see as the radiation passes through that type of material is even bigger. So the difference that you'd see down here would be even greater if it passes through something like metal with a really high electron density as well. So I hope that makes sense. I did have to go through it quickly, but you can always come back and look at the slides and the recording to try and get your heads around it. I still struggle with it sometimes. It is a difficult concept to get your head around. So now let's relate all this kind of thing in terms of what issues we need to consider for different tissue types when we're creating an inverse plan. So let's say our PTV contains an air cavity. So we have this tumor, and let's say in the middle of it, there's an air cavity. Because the air cavity doesn't absorb as much radiation, the planning system can add extra radiation to the air cavity to try and increase the dose here. So if you've got a PTV and you've got an air cavity inside it, ideally what you're telling the planning system is, I want my whole PTV to get 95% dose coverage to my whole PTV. The problem is that air cavity you're going to struggle to get 95% coverage in air because air doesn't really absorb radiation and doesn't really get dose in air. So what you're going to find is the planning system is going to try and pump extra radiation into that air cavity to try and get the dose up within air. So we call that dose dumping. And because of that, what you'll see is the tissue and the air cavity will start to be hotter because you are trying to pump extra photons into that air cavity. And then also because of that, there's going to be extra hotspots through the patient due to that increased radiation passing through the patient with the planning system trying to pump up the dose in an air cavity. So to help avoid this problem, really we want to try and avoid having too much air within a PTV contour. And really we want to avoid the PTV extending outside the surface of the skin. So in my department, we generally reduce our PTV to usually between 2 to 5 millimeters inside the skin surface. just so that we don't end up with a really hot skin dose, because the planning system's trying to pump dose into air that it doesn't need to. And really the opposite occurs if the PTV contains bone or contains a really high density electron density material, because the bone will absorb more radiation. The planning system may reduce the amount of radiation that the bone is seeing, okay? Because obviously it takes less radiation for our bone to get to 95% dose. So it's not going to put as much radiation into that area of the PTV. So then what you'll see is the tissue around the bone may be colder in our treatment plan. And then you may see cold spots through the patient due to the decreased radiation that the planning system is giving the bone. This tends to be more of a problem with thicker, denser bones, so around the pelvis and things like that, than the really fine bones that you might see, particularly around the head and neck or the nasal cavity and things like that. So it's more when you've got thicker, denser bones that you start to have those kind of problems. So to help fix this problem, it's really important to understand that dose in bone may actually be less of an issue. So if you've got a soft tissue tumour, it's often unlikely that the bone is going to have tumour in it. So you may remove the bone from the PTV if that's possible. The other thing you can do is create substructures with different optimization criteria if you need uniform dose to the bone and tissue at the same time. So just an example. So here we have a GTV in red, and then we've got our PTV expansion in this sort of bluey green colour around that. So you can see in our mandible where we've got bone, we've got reduced dose because it is bone, it's absorbing more radiation. And we've also got some cold spots around the edges of our bone as well. And you can see we've got a hot spot in our air cavity here and hot spots just around our air cavity as well. So these are the sort of things that you might see in your treatment plan due to the different tissue types. So how we can avoid this, we could remove the air cavity or the bone from the PTV if that's possible. Obviously, you'd have to speak to your radiation oncologist and make sure that those particular parts weren't something that they really were interested in having specific doses to them. So for example, we've got a case here and we've got the esophagus in the middle, and if our whole PTV is trying to be covered with these air cavities inside it, you're going to end up with some hot spots around our air cavity. If we remove the air cavity from the PTV, you can see that we've got a much nicer dose distribution around our PTV there. So, but obviously those type of things, it's really important you have a conversation with your radiation oncologist. Don't just remove them out of a PTV. Make sure that it is in an area that the radiation oncologist does want or does need dose having coverage. Okay, so what about, I've talked about metal, another really high density material, and how the impact of that is even greater than things like bone. So treatment through or near very high density structures carries a really high degree of uncertainty. And the treatment planning system itself often doesn't calculate dose well in and around those structures. And it may be that your CT scanner doesn't have the Hounsfield unit range. So some CT scanners only have a Hounsfield unit range from -1,000 up to 3,000. But things like titanium and really high density structures have Hounsfield units of 10 or 14,000. So your CT scanner might not even be able to produce the right Hounsfield units for those high density materials to start with. So the treatment planning system doesn't handle it well. So ideally, if you've got really high density structures, so fillings or metal structures within a patient, ideally you don't want your radiation beam to pass through them at all because of the uncertainty in the dose calculation that occurs. So, and certainly high density structures shouldn't be included in a target volume. If you have metal, it's not going to have cancer in it. So it's pretty unlikely you're going to need to include that as part of your target. So, and by including in the target, you're just going to come up with all sorts of problems and trying to get nice uniform coverage. And then another concern with high density material is artifacts within the CT images. I've just seen a question from Simon, which I'll address now while I'm thinking of it. So is it okay to use contrast in a situation where PTV might fall near it? Absolutely, you can use contrast. Contrast is really important for picking up certain things. What you would do if you had a patient with contrast is you would contour the area of contrast, and then you would override the density of that contrast, because that patient's not going to have the contrast in them for treatment. So you would contour the contrast on the patient, and you would override the density of that contrast to the same density as in surrounding tissues. So absolutely use contrast, because that's a really important thing in certain situations. So yes, it's okay.
Stopping for questions, can I communicate a question that was formulated earlier?
Yeah.
So I think it's expanding the topic. I think you're touching up on the basics of concepts of the dose distribution depending on electron density. But we have a very curious attendant, and he would like to know how is that related to tissue phantom ratio, tissue maximum ratio, the knowns TPR and TAR, into accounting for these electron densities.
Oh, good question.
Advanced and sophisticated question.
Yeah, this must be a physicist, I feel like.
Could have been, if that's the case.
No, that's a great question. Look, I think when you're doing like a manual type calculation with TMR and TARs, where you'll find the different tissue density material is when you'll look at your equivalent depth. So your TMR and TAR is not going to change. So it's going to be tissue. So it's still going to be a water to air ratio, but it'll be the effective depth within water that's going to change with the different densities. So let's say you've got 10 centimeters of water, you'd have an effective depth of 10 centimeters. If you've got 10 centimeters of air, you might say the effective depth in tissue of that 10 centimeters of air is actually only 3 centimeters of tissue. So when you're looking at a dose calculation, the different densities more apply to like an equivalent depth more than your TMR and your TAR factors in your calculation. So I hope that makes sense. Hope that answers the question. Good question. All right, no problem. Okay, so yeah, so we're going to talk about high density material, and you get artifacts in your CT image and then how that impacts on your treatment plans. Okay, so let's look at this example. So we've got a patient with some metal inside them, obviously metal in their legs. Here we've got someone with some implants or fillings in their teeth. And you can see that the artifacts that metal has created has really significantly impacted the quality of the CT image. Okay, so we're getting some big artifacts running through these patients. So in some cases, the artifact can impact on the ability to even see the PTVs and the organs at risk accurately. So for example, you've got this big artifact running through this CT slice. Somewhere in here is your PTV, and somewhere in here is an organ at risk, but there's no way you can accurately draw those contours because of the artifacts from those high density materials. Okay, so also if you recall the grayscale of the image, so our Hounsfield unit and the grayscale is required for the dose calculation and treatment planning system. So if you have a slice like this in your treatment planning system, the treatment planning will think this streaking artifact is air inside the patient because it's dark. It's kind of the same grayscale as air. So it's going to think, oh, this patient's got a big tube of air running through them as opposed to tissue. If you look at this one, we've got some streaking artifacts here. So the treatment planning system would think that this is bone or really high density material inside a patient when it's actually just an artifact. And it would think that this part of the patient here is air rather than tissue. So, you know, this can be problematic. So imaging artifacts can have two kind of implications on your treatment plan. One, in terms of accurately drawing your contours. You can't see the tissues properly. And two, in terms of accurately calculating the dose inside the patient. So what would we do in these situations? Sometimes you have to create a contour and assign an appropriate density to the contour. So for example, here we've contoured in all the patient's sort of fillings that they've had and assigned a HU value. So you can see that this is a really high HU. This is like 13,500 HU. So it's a really high density material. And you can see all the tissues surrounding it. We've contoured that in, and we've just assigned that the same density as the surrounding tissue, which is usually, we usually give it around 50 HU. So, you know, and the same thing down here. We've individually contoured the high density material as well as the tissue surrounding it so that we can get more accurate dose calculation. So, okay, so in terms of CT image quality, the better the CT image quality is, the more accurate your dose calculation will be for your patient, and then the better your dose optimization is going to be in your patient. So some CT scanners have inbuilt, you know, high metal artifact reduction software and things like that. Depends on your individual scanner. So some CT scanners will automatically correct for these things, and some scanners won't. So if you have a scanner and you end up getting images like this, it's going to be a reasonable chunk of time for you to create all those sort of contours to override density and create more accurate density within the patient than if you've got that metal artifact reduction software and it can automatically kind of take into account those high density materials in the patient.
Can I pose 3 questions related to all these difference in densities?
Yeah, of course.
One question is, what phenomenon occurs inside the body that in this dose built up?
Oh, what phenomenon occurs inside the body during dose buildup? So do you mean like in the depth dose of a depth dose curve?
If I'm found this correctly, that was when the metal artifacts were introduced. So very deep, very big differences in electron densities. So trying to understand better what happens inside the body when those metal hardware are in the patient.
Okay, so yeah, so if we have high density material and the radiation beam is passing through that, because the electron density is higher, there's more electrons within that sort of area. There's more electrons to interact with the photons, so more of the photons are removed from the beam. So we'd call that, you know, higher dose deposition, because more photons are removed from the beam because there's more electrons for them to interact with. And then obviously beyond that high density material, we now have less photons passing through the high density. So we have less photons to interact with the tissues beyond that. So the tissues beyond that will receive less dose than if the high density material wasn't there. The inverse is true if you have an air cavity. So if you have an air cavity, there's less electrons. So the photons aren't interacting as much. So more photons are going to pass through that material, and the tissue beyond the air cavity is going to see more photons, and thus you'll get more dose depositing in that tissue beyond the low density material. So I hope that answers the question. Please type if that's not. Please type if that's not what what you are asking.
Well, we'll confirm with the participant, with Tuba. The second question asked is, can you do a MB, CT, and fuse with the CT sim to get a clearer boundary of the high density material and overriding the density of the artifacts and high density materials?
Can you get an MV image and align that with your CT image? Is that the question?
Correct.
I'm going to talk about that a little bit later in this presentation. So I might hold that question. If I don't answer it during the presentation, please re-ask it later down the track. But I feel like I'm going to cover that shortly. So I might hold off on that one.
That's perfect. And I think that might apply also to the last question that has been formulated. What of the situation of a patient with a cancer of the thoracic spine with prosthesis?
Oh, good question. These are all, people are really thinking about this, aren't they? Well, each patient is different. So, you know, what I talk about for one patient might not necessarily apply to another patient. So if they've got a prosthetic and you need to treat through it because there is no other option, then that's what you do. I think that there's just an understanding. You need to understand that there's going to be an inherent uncertainty in the dose distribution in doing so. But, you know, if you've got cancer in the spine, that's pretty serious, right? So you kind of need to treat it. So the degree of uncertainty versus the need to treat is outweighed, you know, the benefit is outweighs the risk of doing the treatment. So if you have a prosthesis, you just make sure you've contoured it all and overridden the density of everything around it. And hopefully the artifacts around the prosthesis don't impact on the ability to actually see the spine and the associated area that you need to treat. So it's really difficult to say.
No, yeah, no, very good. I like to say that we actually have exactly the same question in my center right now. So as we are doing SBRT with TrueBeam, VMAT based, and even we have a dual energy CT scanner for simulation, and you can have all the IMAR, artifact reduction. So you use as much technology as you can. Yet our physicists are asking us, can we do an MBCT in our tomotherapy unit to get a better sense of what is the actual electron density to have more accurate planning on dose distribution? So I think it's a relevant clinical question. I don't have the answer, but I think it's a good idea. We're actually pursuing that right now.
Yeah, look, I think there's no clear-cut answer. And I think you're right. People sort of problem solve them as they come up with individuals in their department. So I don't want to give advice on a single scenario that might not work for an individual patient. So it's really about working, I guess, with therapists and oncologists and physicists all talking to each other to come up with the best solution for that individual patient. So.
And I'm going to hold the other questions, so allow you to proceed with the lecture.
Okay, let's go. What's next? Oh, we have a Zoom poll. Yay, we love the Zoom polls.
All right.
All right. So in this question, we've got two different dose distributions here. So the dose distribution on the left is a radiation beam just passing through water. And then the dose distribution on the right, we have a radiation beam that passes through water, and then a different density material, and then back into water. So the question saying, what is that material, with the question mark, that our radiation beam on the right is passing through? So, there's no clear kind of winner here in this so far. If you can't see the poll, I think last week there was a lot of people who had problems seeing or being able to answer the poll. So you can just put your value in the chat as well if you want to still participate and you can't do the poll.
You want to give it a few more seconds?
Yeah.
All right. 5 more seconds for people to participate. We have 30% participants. Come on, guys. We want to see at least 50% to see what the
I'm just
group
going to
is
sit here
thinking.
till people have done it.
All right, we're going to stop it now and see what the answers were.
Okay. All right, so we have it's either air or bone, people seem to think. So with air coming slightly in front, yes. So we do have air. I'm just going to try and get those scribbles off the, let me clear. There we go, now we can see. So air is the correct answer there. So if you remember back to one of my earlier slides, when we showed the radiation beam passing through air and we were getting that lateral kind of scatter of radiation, that's really kind of the giveaway in this one for me. And also the fact that the dose distribution is now not dropping off as quickly. So we're not getting a lot of dose absorbed here as well. So we're getting increase in scatter, so radiation scattering through the air, and we're getting less dose drop off and that sort of hot spot appearing beyond the water there. So so that's why it's air. If it was bone, you'd see a lot more dose absorption in the bone, less scattering, and a dose drop off beyond the bone as well. So 43% did all right. Well done. Okay, just let me quickly clear that. Okay, so we'll move on to the next section, which is now talking about imaging technology for treatment. So this is where we're really talking about our treatment verification, things like that. So let's look at those. Okay, so why do we need more imaging when we're treating the patient? Why do we need to image when we're treating the patient? We've already given them a CT scan, right? So we all know, as radiation therapists, as physicists, as oncologists, we all know patients are difficult to set up. It's really hard to get them in the same position every day and to make sure they don't move. Remember, our last lecture was about motion management. We can see how much people move during treatment. So our targets can move both between fractions, so interfraction. So our targets can move from fraction to fraction, but our targets can also move during a fraction, so intrafraction. And we sort of learned about that last week when we were talking about motion management. And obviously, our tumours and our patients can change shape and size over the course of treatment as well. Patients can lose weight, tumours can grow, tumours can shrink, hopefully shrink over the course of treatment as well. And all of these things can affect the quality of the treatment that our patients are receiving. So imaging before, during, and even after treatment is essential. So, the imaging technique is usually dictated by a radiation oncologist. So they will give a directive as to what kind of imaging that they would like to have for their patient. And in some cases, it's guided by the medical physicist, who I guess probably has a better understanding of the technicalities around the imaging techniques. But the imaging is always delivered by the radiation therapist. So this is why the whole team is super important when we're looking at imaging for treatment verification. Okay, so there are a number of options when we're looking at imaging for treatment verification. So we can have MV-based imaging. So that's our port film, or with plain film or digital film cassettes, or we have electronic portal imaging devices, or EPIDs. We have KV-based imaging. So we have our onboard KV imaging system, You can have a KV cone beam CT or even a 4D cone beam CT. And there are also other techniques for treatment verification. So you can have ultrasound guided treatment verification. It's not widely used, but certainly some places do use it for things like prostate and breast patients. You can use ultrasound guided. And then obviously we had a lot of discussions in the last lecture about optical surface monitoring and surface guided radiation therapy. That was in session number 7. So I won't cover those other techniques in this presentation today. So for MV radiation image, so film-based, so either plain or digital film. So it uses our MV radiation beam to create the image. So if we have a cassette, we've got a high density metal screen inside the cassette to filter out the radiation. The high energy beam hits the screen and creates Compton electrons that then form the image on the film or on the digital cassette. So there are a few issues when imaging using an MV beam rather than a KV beam. And that is you don't get a great image quality from an MV beam. You get poorer contrast. And this is somewhat due to scattered photons and secondary electrons contaminating the image. And the beam also has a larger penumbra, again, due to those scattered photons and secondary electrons. So as you increase your MV energy, you decrease the image quality. And image quality also decreases as you increase patient thickness. So if you're trying to get an MV image through a pelvis, like a lateral pelvis image, often it's really difficult to see an awful lot of information. And if you compare, say, a 6 MV portal image to an 18 MV portal image, again, the image quality is better with the 6 than the 18. Look, film-based MV imaging is really good for 2 and 3D isocenter checks and for localization of standard treatments. And sometimes, depending on the field shapes and sizes that you're using, you may require a double exposure to get more anatomical information to determine whether your patient's set up in the right position. Obviously, due to development and processing time, you know, having to go and take the digital film and put it in the film processor or your plain film, again, processing the film, film-based imaging can be really slow. And we consider that it's too slow for accurate IMRT treatment delivery, particularly if you're using tight margins. So the idea with IMRT is you have really tight margins around your GTV, so you might reduce your PTV margins. And obviously we saw from our last lecture about how much patients can move inter and intrafraction. So if you've set up your patient perfectly and taken the film, by the time you come back from processing a film in this way, the patient's probably already moved. So using plain and digital film for an IMRT type treatment really isn't recommended as a localization method. What we would recommend is using an EPID, so an electronic portal imaging device. So it's a flat panel detector mounted directly onto the LINAC, opposite the treatment head, as Simon is dropping me to show you.
Let's try to get rid of that.
Clear that. Perfect. Thank you, Simon. And so the most common type of EPID that you'll see on a LINAC is a flat panel made of amorphous silicon. So what happens is there's a scintillator inside the EPID that converts the radiation into visible light, and then that light is detected by an array of photodiodes that is implanted into the panel. And these photodiodes are really, really small, so less than 1 millimeter. So you've got thousands and thousands of photodiodes. So the resolution of the image is really good. So less than 1 millimeter, you're picking up light, and so the resolution of your EPID image can be really good. And because it is electronic, there are different processes you can put in place to improve the image quality as well. So the advantages of EPIDs, it's just super easy to use and position the detector. Often you don't even have to go into the room. You can just hit the button, the EPID panel will pop out, you take your image, it'll pop away again. You use the treatment beam to generate an image. So that means that your imaging center will match your Linac ISA center because it is exactly the same beam. So it allows instant online verification. So you're seeing an image in real time. So our department makes use of what we call cine imaging, which is like cinema, like movies. And so we take cine images of our patients. So you actually get a movie of the patient in real time as the treatment is going on. So you can take multiple images during one treatment without needing to go into the treatment room at all. And obviously there's direct connectivity and integration to the treatment unit and the treatment planning system as well. So it can integrate and do a lot of analysis for you on the fly. Excuse me. So what an EPID can do is online verification of bony landmarks or implanted fiducial markers. So MV imaging isn't great for soft tissue visualization, so it's really good for bony anatomy and high density information. So you can automatically register the image with digitally reconstructed radiographs from your treatment planning system. So your treatment planning system will take the CT that you've put into it, and it will create, I guess, a reconstructed image of what it would think a 2D radiograph would look like from that CT data.